Is my screen visible to everyone?
Yes, it is visible.
Yes. Okay. So we're going to discuss about ethics in palliative care. I'm sure the group may have learned many things out of their experience in ethics. But the importance of ethics in palliative care has been always upheld. And we would like to discuss today about the four cardinal principles and an important topic, a hot topic called euthanasia. So, by definition, this is ethics are basically the moral code of behavior of a group of individuals or professionals, and the ethical principles are a set of principles in a moral account which should function as an analytical framework that expresses the general values underlying common morality. So the important word that is repeated here is, the morality or the moral account. Basically, ethics of palliative care or palliative medicine are exactly the same as those of medicine in general, because interestingly, doctors play a dual role in life, in their responsibilities. Firstly, to preserve life, and secondly, to relieve suffering. And we have to understand that at the end of life, the relief of suffering becomes more important as preserving life becomes increasingly impossible. So the four cardinal principles as applied to palliative care practice are autonomy, beneficence, non-maleficence, and justice. When we talk about autonomy, the main question that comes is, what does the patient want? What are the preferences of the patient? And does this the family of the patient requires, understands the preferences of the patient? When it is beneficence, it is as simple as, will the steps taken by us or the patient family will benefit the patient at all. So the patient is definitely at the core of it. Non-maleficence, will it harm the patient? And justice, is it a fair utilization of resources? The kind of resources that we are using to make the patient comfortable or treat the patient at one point of time, is it actually justified even? Are we trying to get some resources pulled out of another needy patient and give it to this particular patient? So these are the four palliative care principles or cardinal principles of ethics, and our practice will generally depend on these four pillars of ethics. There's something called ethical dilemma where we generally see ourselves or feel like falling into a trap when there is
Dr. Sanghamitra?
I was talking about ethical dilemma, and we find ourselves, fighting with our own self to justify what we are doing, because at one instance we feel that this particular work or step of ours is ethically right, but then at the same instance, we find ourselves wrong also, because there's some other issue which comes and disturbs us, and which also, the other option also seems to be quite okay. So this is the kind of problem which is called a dilemma, and it is a conflict of moral principles occurring when a person faces certain situations where adhering to one particular principle might result in the violation of the other. And to understand this better, let us take some examples. So I would like to have some responses from the participants here. This is a patient, and he has a jaw tumor with an orophytic fistula. You can see on the right hand side the picture. It is a ghastly picture with all kind of a disturbing kind of sight for all of us. He's an elderly patient and he's in extreme pain, but there are no distant metastases. So the doctor decided that we have to give him a NG tube, so that since he's not able to eat anymore, at least through the NG tube there'll be some nutrition to maintain his health. But the patient is refusing to take the NG tube. So what is our stand on it? How would you, what will you do if you are in the position of the doctor? Can I have some input from our participants?
Hello.
You can give your,
Hello.
yes, Mr.
Yes, Dr.
Biswas. Yes.
So I am Arnab. I am a family physician. So in family practice, we have a term called reaching common ground, where whenever patient is in a different page and we are in a different page, we actually try to come to one negotiation where both of us will fairly agree to the same treatment. So if the patient refuses, I think we can only talk about choices and consequences, and we can talk about what is the consequence of his decision. And if he's how do I put it? We have to first actually assess the mental status of the patient on whether he is able to make a conscious decision on his own. Because sometimes if the neural system if the cognition is affected, maybe they will make choices knowing that it is maybe not knowing that it is harmful for them. So first we have to assess their cognition and their understanding, and nobody actually wants suffering for themselves. So when we understand that this patient choice is leading to his increased suffering, we can maybe try to understand his perspective and come to some common ground. So we can actually ask why he wants to refuse, and what are other options. If not an NG tube, maybe will it be better if he wants an OG tube or even a feeding jejunostomy, which is actually hidden from the other people under his clothes. Thank you.
There are other responses which is more like patient wishes to be respected, if that is what patient wants, and try to talk to relatives to convince the patient. It's one different response.
Yeah, and there is one response which says that we can counsel him and explain him risks and benefits of NGT, and in common language, we can explain that the sudden deterioration in his health might be due to decreased intake and not due to cancer or tumor per se. Okay, and
also
all right.
to Dr.
Yeah.
Arnab, we hadn't addressed, since your slide says that the patient is currently in pain. I think if the pain is untreated and you are completely, and if you are counseling for NGT, I think anybody would refuse, because I think severe pain does not let us think straight in the first place. So, I mean, it is observed and it is a noted fact, I think, that a person in pain cannot think of anything else except the pain. So I think only after proper pain relief, the counseling would actually might have some effect to whatever.
All right. So there is another response from Aisha Jalil, who says that we cannot put NG tube we cannot do an NG tube insertion without the patient's consent. If financially okay, peg insertion is accepted better, because most of the time people are intolerant of tube through the nose and the inconvenience. Right. We have one more. We can try making the patient and family understand the benefits of NG tube insertion and how it can improve his quality of life. Need to address patient's sales needs first. Right. So I think partially all of us are actually coming on to one page or one decision. But having said this, we are actually not right now talking about what are the alternatives to NG tube insertion, number one. Number two, if the patient is in pain, consider it, consider it to be treated properly in the next step. And still, if find that the patient is refusing, then what to do? Then what we do? So this, suppose the patient is not in pain, suppose the patient's cognition and his way of thinking, his attitude, everything is good. He understands everything, but at the last he says, no, I am not going to take any NG tube. I'm not going to, consent for this. So what we do next? So,
Hello.
Yes. Yes, please. Hello.
Sanghamitra ma'am, you may continue.
Okay. So this brings us to an ethical dilemma, which is between doing good, because we want to benefit the patient and we want to do good to him, improve his nutrition perhaps by giving him an NG tube. And it is also a choice between, the patient's autonomy, because the patient is refusing, despite of all the things that you've told about the benefits of the NG tube, and the alternatives of the NG tube, and in despite of taking care of the pain also, the patient still says that I will not take the NG tube. So this is an ethical dilemma here between doing good and the autonomy of the patient. Let us understand what is this autonomy. What does patient autonomy generally mean? It means the patient is involved in decision making. And for that reason, he has the right to have dignity. He has the right to privacy. He has the right of confidentiality also. He has also the right to have the correct information. He has the right to make decisions. And last but not the least, the treatment decision has to come as an informed choice of the patient. So this is regarding patient autonomy. And for this patient, if he is not, if he is refusing to give you a consent for NG tube, please take an informed refusal. And when we say informed refusal, it means you check the understanding of the patient. As Dr. Arnab and all of you have already told us or already shared, that we have to see how much the patient understands about what will happen if the NG tube is not there. If he is not taking the NG tube, what might happen? So check the understanding, whether he is really understanding the consequences of that, and then explore the reasons. Even when he says that he's understanding, he's still not actually, coming in the same decision as you are. So why is he doing that? So explore those reasons. He might have some other reason. He might have something going in the background, in his background. Maybe he's a little depressed about what has been happening, and he's trying to, cut off everything, all treatments, everything that he's, or otherwise it may, he may be thinking that I'll become a burden. I won't be able to eat food. It's not normal for me to take a kind of a pipe on in my nose and then go around. What will be? So we have to explore these reasons also. And then, as rightly told by you, we need to counsel him. Counsel not by trying to overpower on what he has already understood and what he is trying to say, but counsel him by trying to understand his reasons of refusal. Okay, listen to his problems, listen to all his agony that he might go through after getting an MBT. And then, even if after all these things that you have done, all the mehnat that you have done, the patient still refuses, you will need to support the patient. And you will, even if the patient is not agreeing with your decision, you must support the patient. There will be two things here if you support the patient. Number one, you will always remain open for the patient to come back to you and tell you that, doctor, I think I was wrong about taking a decision of not taking the YouTube, and now I want it. So, so there will be a time, there might be a time in the future which might give you a chance to actually put some confidence in the patient that, yes, I think the decision taken by the doctor for putting a RISE tube or a IV tube for me will be right, and I'll be benefited, and I will now go according to him. So, your friendliness, your rapport with the patient till the time you reach your goal of benefiting the patient is actually coming up to that particular level. And so you will not close the door at that instant. It should not be like, okay, आपने ये नहीं मेरी बात सुनी तो इसीलिए आपका ऐसा हो रहा है. It must not be like that. You have to be tolerant till the patient sincerely decides. And I will tell you from my experiences that there have been instances, not many instances, where patients have actually come back to me and told me that, yes, you were right. I'm sorry that I've come late, I've taken this decision late, but then I will go by your decision. So, this is how you respect patient's autonomy and work towards his benefit. This is another case, and this patient actually wants treatment. He's a 20-year-old boy with osteosarcoma of the lower end of the femur, as you can see in the right picture. Now he has a large tumor. He has multiple lung metastases, and he has severe anemia. But he wants an amputation now. But the procedure is too risky considering his general condition. So you explain the risk to him, but he wants to continue with the amputation. What are your take on this particular case?
Hello, yeah.
Yes.
Yeah, I'm Dr. Smita here, anesthesiologist.
Yes,
I just wanted to say that this patient's risk for surgery can be mitigated or reduced by optimization prior, since he's a young boy, and there is a room for correction of anemia, correction of, I know the lung mets are there. He may have a stormy post.
Hello? We can't hear you, ma'am.
Yeah, sorry. Yeah. So considering his age and optimizable factors, he might like pull through surgery. There may be an adverse outcome, a longer post-operative stay and things like that. But I think we have to talk to convince, and from our side, do our best to reduce his risk for surgery.
Okay, so you're telling me that you would also actually go with the decision of doing the surgery?
Yes.
For this patient?
Yes, considering the means seeing the entire picture. Even if there is a
So there are multiple lung metastases. The patient has severe anemia. You can see the huge kind of the tumor on the femur, lower end of the femur. and but still you would like to go with the risk. And what if the patient dies on the table?
That would be that is in the informed consent. We know that there is a chance that the patient may have issues on table. Definitely, we have to be.
So exactly. So would you want that to happen?
Nobody would wish for such kind of an outcome. But even if there is a chance,
what would be the chances of this outcome? The chances
that's
of the
considering
outcome that the patient is going to die on the table.
Yeah. So
what
if
are the
the
chances?
factors are optimizable, with like the anemia can always be corrected before, and always definitely the patient, when we do take up for a person for surgery, definitely it has to be at a center which can handle such a mass. It cannot be we have to take that decision, and we have to refer the patient to the correct place where they can manage it. And
so there is a factor which there is a cost factor involved in it. There is the question of transportation of this patient to that particular center which has these support system. The patient must be able to afford that particular operation or that particular situation. So what do you think? Are we sincerely going to operate on him? As a palliative care physician, I would not want my patient to go, for this particular surgery, because as we know, as you can see that the patient has multiple lung metastases. He also has severe anemia, and these are attributed to the very advanced terminal nature of the disease. And when they have the patient has a terminal disease, perhaps he's at the end of life also, we would not actually go for any kind of interventional procedures for any kind of patient. We would rather stop everything and take care of the patient. That is my take on it.
Hello.
Yes.
Hello.
Yes, sir.
Yes, Dr. Furi. Yes. For a treatment to be appropriate, you always have to weigh the risk and the benefits. And for every treatment, once you weigh the risk and the benefits and you notice that probably the risk outweighs the benefit, then there is no need. So for me, I similarly think, even though the patient wants the amputation, but then that is not an appropriate treatment, as the previous speaker has said, the disease is already way advanced. So it and stress on the doctor who will want to go and do the surgery, and then at the end of the day the patient ends up dying. So it goes with a lot of counseling and a lot of other interventions that will keep the patients calmer and keep the patient free from pain. So we allow him go if he has to go. Thank you.
Okay. Any other input from anybody else?
Yeah, I think there are a lot of messages in the chat, starting from the primary reason for amputation might be the uncontrolled pain. So it's better to start with better pain control and explaining about the death on table, counseling on risk versus benefit, and offer palliative treatment. Yeah. So important is to give palliative care. Surgery can be denied, relieve his suffering. So a lot of responses in the chat.
Okay. There, Dr. Arnab has an interesting hold. He says, suppose this boy files a lawsuit saying this doctor is refusing surgery, which I want. I will pay and I understand the risk. Then will that argument hold in court? Okay. So absolutely. So there are, these questions, we are actually going to see what happens. There is an ethical dilemma between doing good, beneficence, and avoiding harm. So when you know that your risks are outweighing the amount of benefits that the surgery will cause for this particular patient, then there is an ethical dilemma between doing good and avoiding the harm. So what happens is that, the questions that we need to ask for ourselves and also the patient, the insight of the patient is, what are his chances of cure? Because uh, the patient does not understand, the palliative intent or the curative intent of doing something. You have to make him understand why we are not doing the surgery or why we are doing a particular step, particular treatment. So ask him, does he understand what are the chances of his cure? You ask yourself, you ask your team, you ask your multidisciplinary team of the doctors, the oncologists, the surgeons, the other team members. You ask them. You tell you find out for the reason of not going for the surgery yourself, and then uh, is the survival likely for this patient? As I said, that there is every chance that you put the person on the table, and by the end of the surgery, the patient actually goes out of our hands. Will the amputation improve his condition? Is it going to be better? Is it actually going to relieve him of the pain? As somebody said in the chat, bone pain can be taken care of. It might be a messy thing, but then we as palliative care physicians and pain management specialists, we are trained to take pain on our hands and manage it to the best possible extent. But amputation, will it actually improve his condition? Will it actually stop the tumor from growing, or will it stop the metastasis in the lungs from growing? So all these questions we need to ask. So the point here is, all these questions, once you try and find out the answer, you will be able to talk to the patient about the chances. And that would mean that you will need to search for your communication skills at this point of time. Ask him what are the reasons that he's thinking. Why is he in a position of denial? Why is he trying to think? Has he read somewhere? Is there any Google, kind of Google Baba telling him that yes, at this point of time also you can go for a surgery and then find a cure for yourself? Has somebody told this to him? Has he found out? Because a 20-year-old is an adult, and we need to always understand that he is in a position of denial. How can I be in this position? How can I not get cured of this particular thing? So the counseling part here is the most important part. You may have to have the help of your counselor in the team. You might have to have a lot of sessions along with the child, and then find out all the reasons. The best part is to listen to what he has to say, not just give him all the gyan that you want to give him, but sit with him, try to find out his insights, try to find out what he has read about this, try to find out what he is thinking about his life, how much he is going to survive. And these two questions, is the survival likely, and will the amputation improve his condition? Both of these questions has a lot of answers in store. So this, so coming to another ethical dilemma, a 20-year-old boy with advanced cancer is under your care. Relatives have insisted that issues of diagnosis and prognosis should not be discussed with him. So when you go to see him one day, he is all alone, and he asks you what is wrong with him. What will you tell him? And we have some answers.
Hello.
Yes. Yes, yes.
Yes, so this is really interesting, and owing to the fact that the patient is 20 years old. So I think the first thing was when the relative would have told you not to tell the patient about his or her diagnosis. Is the time you really have to talk to the relatives about the needs of you telling the patient his or her diagnosis. And as it is rightly stated here, the patient is anxious, wanting to know his diagnosis. And definitely issues are having to do with trust will come in if you don't tell that patient his or her diagnosis. So it's a matter of you really having good communication with the relatives, reassuring them that even though they don't want you to tell the diagnosis of this patient, but then it will be much more beneficial to the patient and will help the patient. The anxiety will go away, even though it might be difficult at first, but then he will learn to understand it as time goes by. Thank you.
Thank you, Dr. Fourier. Thank you so much for your answer. And
I think Dr. Arnab has raised his hand.
yes, Dr.
Yeah, so there's a saying in English which says that the peacemaker gets blows from both sides. So I think I think we should. I would personally avoid being the peacemaker and receiving the brunt of a relative saying, "Why did you inform him?" and the brunt of, on the other hand, the brunt of the patient saying, "Why are you not telling me what is wrong with me?" So how I look at it is that I would make all of them sit in one room and maybe talk to each other and just coordinate that discussion in a way of that breaking bad news protocol, which is like the spikes or the breaks protocol, and maybe let them talk to each other and try to figure out a common ground on uh, what the information that is to be conveyed. Yeah, thank you.
Okay, that's very interesting. Uh, I
And
think
there
we
are
have
chats also
chats,
regarding
yeah.
this thing. Yeah, as the
Breaking bad
council.
news should be done very gently and stepwise. Fear of not knowing what is going on is what troubles you more. Absolutely. The more we don't tell him, the more anxious he'll become. Definitely, yes. Phrasing is important. Okay. We counsel him and help to sort out his benefit of palliative. Okay, that was, I think, the previous one. So, yeah, there are interesting, I think, inputs from everybody. And I'm so glad that people are taking part in this chat. Anyway, so, so, so right now, I think, we are in a dilemma where we are deliberately, perhaps, we might mislead a person by, or to withhold the information that the person is asking for at the insistence of the patient's relative. This is an ethical dilemma, and this is a huge communication problem because the patient's family members, the parents, the uncles and the aunts are actually trying to protect this child. He might be 20-year-old, but he's always a child for the patient. For the parents. So they will definitely try to protect him from any kind of harm, and they're justified. I mean, I have an 18-year-old son, and I would be always protective about him. I would actually treat him as a small child till now. And it is with the same, sentiment that the parents of this particular patient is also doing. So, I will not actually sincerely blame the parents or the relatives for withholding the information, but then it will be on my part. It will be kind of a deliberate action to mislead my patient by withholding that information. Where as Dr. Foray has already said, and many of the people in the chat box have also come out that we are not actually justifying why we are withholding this, because number one, at 20 years, the patient is an adult. The patient has all the rights to know about what is going on with him. And it is our moral duty to actually give him the information that is required. So here I would actually go with Dr. Biswas, Dr. Arnab, that he has said. I would actually bring everybody to one table. Perhaps before doing that, I would talk to the relatives once, why they do not want to, give that information, and as understandable and predictable, everything that we have discussed till now about protecting one's child from harm would actually be told to us. And at that point of time, we will need to give them this information that no, these are the benefits of giving this information to your child, because that perhaps he is in the last stage, his days are numbered, and he might have certain plans in life that he might want to share with you. And once he's not there, you will always blame yourself for not getting that insight from your child, what he wanted to do, where he wanted to go, whom he wanted to meet. So all these things are important at this particular stage of life. And you must, even if you are getting hurt by this thing, this particular sentiment, you must actually try to give little bit of information about the ultimate problem, the ultimate day that is very nearing for your son's life. So I think that is an important thing. And then, of course, try to talk with the patient regarding his insights, why he wants to know. You might actually open a Pandora's box by asking this particular question. Why do you want to know at all? He might give you so much of information that you had never imagined. And this has practically happened with all of us. With us physicians, we have been practicing palliative care since such a long time, and unfortunately have been dealing more with end of life care than taking care of patients at the first or second stage of cancer, so to say that. And hence, we have seen that asking this particular question, why do you want to know, has opened so much of issues, has given us so much of chance to actually bring in bridge the gap between both the people, the patient and the relatives or the parents. And this has actually cut off the kind of conspiracy that goes on when it is all silent between the two parties. So it is very important that we do not fall into this trap and help both of them, both of the patients and the parents or the relatives, come to one particular platform and discuss it out, cry it out, perhaps take out, vent out everything, every emotion that is there inside. And then you see the kind of magic that happens. I have experienced this in my life, and I'm sure, when you start practicing as palliative care physicians, you're also going to do that. So now, another interesting thing that we have here is that there is a 50-year-old. Yes.
Sorry to interrupt. So there was a question, if it's the same, if the patient is below 18, which is a child, 8 to 10 years old.
Yes, I think it has to be the same, because the only thing that will be different is the way that you, express. You might have to take into confidence a trained counselor or a trained pediatric palliative care physician for that reason. But I'm sure, the children, I would actually understand them as one of the most intelligent people in this world, because the only disadvantage they have is that they are unable to verbalize their thoughts. They are not able to express their thoughts. So we will perhaps need to leverage on that particular aspect, that we will need to give them one platform where we understand what they want to know, how much they want to know, and make the parents understand their child's sensitivity, their child's dreams, and every hope that he or she has. So I think for a child who's below 18, it is the same, and for above 18, it is uh, pretty much the same as an adult. Does that answer the question?
Yeah.
So,
Dr. Manjari.
yes. Are there any other questions regarding this?
There is one comment by Dr. Arnab telling that I believe the nominated representative takes the call in case of minors. Need to establish one or two non-related nominated representatives in this case.
Okay, so I think, yeah, I have. All right, so I definitely go with Dr. Arnab because I believe the nominative representative would be maybe somebody from the point of the child, from the child's side. But then I would prefer talking to the child myself, because there'll be when somebody else talks on behalf of the child, there is always a possibility of distortion of the message. So I would want myself to talk to the child. It is similar to you examining a case of appendicitis rather than believing in somebody else's transmission method. So I would actually like to say like that. Okay. So yes, sorry. So this is a 50-year-old lady with carcinoma of the stomach and has come to the hospital in a terminal state, probably due to internal bleeding. Her systolic BP is 50 millimeter of mercury. She is very restless. Will you give her parenteral midazolam, which may hasten death? Any take on this particular case?
Oh yeah, you have to weigh the risk and the benefits, and then the reason for which you are giving the midazolam. If you think the restlessness is what is much more worrisome, or is what is much more stressful to the patient, then you go ahead to give the midazolam in the therapeutic dose. No matter what will happen at the end of the day, I think it is morally justified.
Absolutely. Absolutely, Dr. Forde. Anybody else who would like to comment?
There are a lot of responses in the chat. Some of them say no, not in a state to make a decision, treat the suffering first. The family needs to be counseled.
So, Dr. Mrinalini says no. Dr. Mani Kumar says no. Okay. So, Dr. Rajni also no. So,
there will be litigation told by Dr. Smita.
Okay, Dr. So there'll be a litigation. Okay. All right. So now there's a question that is it right to give some medication to a terminally ill person which may inadvertently hasten the person's death? What is the answer to this question?
Come again, ma.
Yes. So the question for the previous slide.
Okay.
Sorry. So this is the case. So this is a 50-year-old lady with CA stomach. She has come to the hospital in a terminal state, and probably the terminal state is due to internal bleeding. Her systolic BP is 50 millimeter of mercury. She is very restless. She is extremely restless. Will you give her parenteral midazolam, which might hasten death? So for this, we have answers it's a complete no, I think, from the whole house. But having said this, is it also right to give some medication to a terminally ill patient which may inadvertently hasten the person's death?
Yes, it is right. You can give.
You can give. Okay. So I get a yes from just one person, who is Dr. Kore. I think all others are okay. Yes, kind to relieve the suffering. Okay, Dr. Shalil Kumar. Midazolam, will it affect BP? Okay. Yes, if it is relief or suffering, the consequences of death is not relevant here. Okay. No, we should not. All right. So, who says it is not right? Why do they feel that it is not right? Why do yes, please.
வீட்டுக்கு போலாம் நான் அந்த இது மட்டும் வாங்கி தந்துடுறேன் போலாம் அந்த பழம் மட்டும் வாங்கி தந்துடுறேன்
Okay. So no midazolam, but I would like to stabilize the patient with fluids and not speculate that low BP is due to internal bleeding. Okay. And no midazolam. We are seeing as this is inevitable at that point. Yes, it may. I think this answer may be touching spiritual beliefs. As a Christian, I won't take someone's life in my hands. Okay, we can count you for DNR. All right. So going back to this particular case, when you see the patient is very restless, the patient is in a terminal state, and if I assume that your classes on end of life care has already been done, then I will assume that you all know about the fact that parenteral midazolam is the drug of choice, is the gold standard of relieving terminal restlessness. And having said this, when we know that this patient has a background of advanced carcinoma of the stomach, has come to the hospital in that particular state where her BP is, systolic BP is 50, we have to speculate that this is perhaps because of internal bleeding. And that is definitely justified. And henceforth, when the patient is in terminal restlessness, we will treat her with IV midazolam. Okay, that is my take on that. Maybe Sri Devi, their classes on end of life care has already been done, I think. No?
Not yet. It is towards the end of the course.
Yes. So I think your answers to many of the questions, many of the dilemmas that you're now going through after looking at this particular question and hearing my answer will be answered in that particular class. But I would like to reiterate the fact that midazolam, IV midazolam is the drug of choice, the gold standard of treatment for terminal restlessness. Okay. And interestingly, the question that will now come is that, is it right to give some medication to a terminally ill person which may inadvertently hasten the person's death? Where, IV midazolam is actually causing, the restlessness to come down, but at the same time, it might also hasten death. So we all know about the principle of double effect. When you had gone through your module on pain management, you must have come across the principle of double effect, which says that a single act of having two possible forcing effects, one good and one harmful, is not always morally prohibited if the harmful effect is not intended. Here in this particular case, our intention was to relieve the patient of restlessness. Terminal restlessness is extremely disturbing for the patient. It is extremely disturbing for the caregivers. It is extremely disturbing for the medical fraternity also. So it is important that we relieve the patient of this particular suffering. And henceforth, instead of straining that patient's hands and legs, we would want the patient to rest with, some peace with IV midazolam. It is not always seen that IV midazolam has, hastened death, but there are instances where the patient might actually go away while the patient is sedated with IV immobilization. So always follow the principle of double effect. Okay. We come to another last case of ethical dilemma, and this person is a 70-year-old gentleman with advanced carcinoma of the lung who had completed a course of radiotherapy and 2 courses of chemotherapy. Is brought to the casualty. He is drowsy, his pulse is feeble, his systolic BP is 60, and the breathing pattern is altered. The family wanted everything possible done for this patient. So what do we do in such situations? Do we resuscitate and shift into the ICU? Do we investigate further? Do we see the hemodynamic and ventilatory supports available for this patient? Do we also go on hydrating and giving nutrition to this patient? So what is an appropriate treatment? What is the definition of giving an appropriate treatment to a patient? It is that treatment which does not provide net benefit to the patient, which may be ethically and legally, the treatment that does not provide net benefit to the patient and may ethically and legally be withdrawn, and the goal of medicine should shift to palliation of symptoms. And that is what we call appropriate treatment. Here, for this particular patient, who is a patient of 74 years, he has an advanced carcinoma of the lung. He's already completed so many courses of radiotherapy, chemotherapy, and right now extremely drowsy, perhaps in the end of life with a feeble pulse and a low BP with an altered breathing pattern. The family is actually had gone far for doing everything possible for this patient. And right now, when the patient has been brought to our casualty in such a situation, the appropriate treatment will not be to resuscitate him and shifting him to the ICU. There is no point of giving him any kind of investigation. There is perhaps no point of doing any kind of ventilatory support for this patient also. And perhaps hydration and nutrition will never work for this patient. And henceforth, we will find out the kind of appropriate treatment which will be not doing actively anything for this patient, but to support him in the last phase of this life by taking care of perhaps his restlessness, a little bit of infusion, subcutaneous infusion of normal saline, or maybe Rindelactate might help him. Maybe a little bit of oxygenation also to just make the process easier for him. So that brings us to, I'm so sorry about this, appropriate treatment key points. We need to see the patient's biological prospects, the therapeutic aim and benefits of each of these treatments that we do for such patients, the adverse effects of each such treatment, the need of not prescribing a lingering death to these patients. So these are the appropriate treatment key points. The last but not the least, the principle of justice. It says we need to balance the needs of the individual with that of the society. And many times, especially in a country like India, which is overpopulated with, just a ratio of perhaps 1 is to 1,000 beds, 1 doctor for 1,000 patients. Are we actually justifying the use of available resources for our patients. So this is a case where the justification of allocation of resources might come up. He's an 86-year-old person. He was a war correspondent and a cancer of the lungs, the spine and the rib and the sacrum. His breathlessness has been increasing because of the advancing nature of the lung cancer. So do we actually treat him with an ICU admission? Is it justified? Can that bed be actually utilized for another young person who just had come to the casualty with a brain injury, or RTA patient who has come to your casualty? Would you not, there is just one bed available in the ICU, would you not give that bed to that particular boy rather than allocating this particular bed to this gentleman who's 86-year-old? So is this a fair utilization of the resources, of the family's resources, of the allocation of the hospital resources and the society's or the nation's resources? So that is where we need to perhaps justify how we allocate our resources for them. This brings us to something called euthanasia. It means it's an act or procedure in which someone takes active means, such as a lethal injection, to bring about someone's death. And allowing natural death or withdrawing a futile treatment is not called as euthanasia, and it is legal in Netherlands, Belgium, and Luxembourg. So these are three important facts about euthanasia. There is a legal provision in the ICC section 88 justifying the act of which is not intended to cause the death, but done by consent in good faith for personal benefit. Unfortunately, we don't have much experience of translating this legal provision into clinical practice. So, what is futile care? Physicians are not ethically obligated to deliver care that, in their best professional judgment, will not have a reasonable chance of benefiting their patients. This is given by the AMA Code of Medical Ethics in 2009, and that actually protects the physicians, by saying that physicians are not obliged, not ethically obligated to deliver care that, in their best professional judgment, will not have a good chance of benefiting their patients. So all these ethical dilemmas that we have actually discussed about, and feeling that we might tend to slip into giving our patients a kind of care which might prove to be futile, we are actually not ethically obligated to do that, because in our best professional judgment, we know that this kind of care is not going to benefit our patients. So why do doctors go for futile treatment at all? Unfortunately, physicians are oriented to curative treatment. Whatever happens if a patient comes to us, it is a natural tendency. It is the natural inclination of every doctor to give a curative treatment, to see the patient get up from the bed and walk around like a normal person. This is but a natural thing to do. Unfortunately, our doctors are not much trained in palliative care, and henceforth, the property or the the nature of accepting failure is seldom seen in other doctors. We as palliative care physicians, as we accept failure in our part to not give, extend the life by days, but then making the remaining days of our patients as good and pain-free and suffering-free as possible. As we already discussed, there is also a lot of fear of being blamed for suboptimal treatment. That yes, doctor, in your hospital, under your guidance, under your treatment, my patient has not received hydration, my patient has not received a PPN, my patient has not, undergone any kind of surgery. You have refused to do these things. So these are the fears that a doctor already has of being blamed of suboptimal treatment. And there is ignorance about the guidelines for end-of-life care. And what about the question of euthanasia? Will he ever be able to, answer if somebody actually deals with them that, oh yes, when you are withdrawing all the treatments, you are stopping everything, you are actually doing euthanasia. So there is a kind of a lot of confusion about the whole process. So you can actually go through this very interesting position statement, and this has been jointly given by the Indian Society of Critical Care Medicine and the Indian Association of Palliative Care. There's a big descriptive end-of-life care policy, and they have given an excellent 12-step process to approach end-of-life care. How you approach, what are the steps that you can take, what are the important guidelines that are need to be followed when you do a end-of-life care for a patient. And in all these things, the art of prognostication must be very good. You have to have a lot of practice in doing that, unless and until your prognostication art is good, you have a say on the prognostication of your patient's life. I think there'll be a lot of confusion that will be created between the physician and the patients and the patient's parties, because of which there will be a lot of uproar in you providing them the best possible care. This logical distinction between killing and letting die, at times becomes very, very, very problematic, because there is a moral prohibition for killing. We all know that we can't go on people, killing people, but people will invariably die at some point of time. We understand that this particular fact, and this is a fact that sometimes dying patients are given futile treatment, which compound their suffering, and so there is a need for letting the patient die. And this will also necessitate withdrawing or withholding the treatment with the advent of modern technology. The distinction between killing and letting die will appear blurred in some situations. Sorry. So, you see, prolonging the life is good, but prolonging the dying process can never be considered good. So we have to make a distinction between killing and letting die. So euthanasia is an important fact to understand, and the definition of euthanasia needs to be understood, that it is always active. When you are deliberately doing an intervention, with the expression of ending somebody's life, with an intention to end somebody's life to relieve the intractable suffering, then it is an active intervention that you're doing. Henceforth, there is nothing called passive euthanasia. It can never be passive. It has to be an active work and something which is done intentionally. All right. So you understand the fact today that euthanasia is neither active euthanasia nor passive euthanasia. It is always an intention to end somebody's life, and the intention might be to relieve some an intractable suffering of a person. Okay. So please understand that there is nothing called passive euthanasia. So coming to something called do not resuscitate, these things have just now started in India and have been going on since quite some time. There are civil society uproar about how we can put in DNR into place and bring in advanced directives for this method. So my question for the class today is, do you think using morphine and other drugs to relieve pain will be called as euthanasia? Will the stopping of treatment when the burden will outweigh the benefits will be called as euthanasia? And will allowing the nature to take its course when the patient is dying will be called euthanasia? I leave these three questions to you to ponder about, to see in the literature, to read about euthanasia and the latest guidelines that the end of life policy statement has given us. Please go through that. Please understand about euthanasia, and please practice the best of palliative care that you can. I will also recommend you all to read this particular book. I'm sure many of you have actually read it by Atul Gawande. It's an excellent, lovely book, lovely insight by this very, very famous surgeon. And he has actually gone on to say that our medical system is excellent at trying to starve off this with chemotherapy, intensive care, and surgery. But ultimately, death will come. And no one is good at knowing where to stop. So, he being a surgeon, have seen so many deaths and has actually come out saying this. So please do read this book, and there you will find a lot of insight and a lot of answers to your questions also. We just cannot afford to die in the ICU. At least I am sure that I will not die in the ICU. Interestingly, these are the facts. 85% of healthcare spending in India is out of pocket because people go and spend it for dying in the ICU. 39 million Indians are becoming poorer per year due to the rising healthcare costs, and most related to aggressive medical interventions at the end of life. You can actually imagine. I remember my grandparents dying, inside their own home, surrounded by all the kids, every family member, the whole village coming in, doing a kind of a puja for them when they are in the last stage. But then, after a few years, I actually found my uncle who was suffering from CA lung dying in the ventilator. There was an extreme difference because we actually couldn't visit him in the last days of his life. He stayed in the ventilator for around 1 week and then he died without seeing anybody, without seeing his son or his daughter. And this has been actually happening to become a trend, kind of institutionalized death for maybe for the modern generation people. There has been an 300% increase in inpatient expenditure in the last 10 years. So, we just cannot afford to die in the ICU. It is just beyond imagination for a normal person. So, apply ethical principles against the background of respect for life, that is important, and the acceptance of ultimate inevitability of death. If we understand that, if we accept that, I think many things will become very, very easy for all of us. Thank you so much for a patient hearing, and maybe we can just take your questions for.
There are a lot of discussion happening in the chat, but I'm just worried we are kind of running out of time for the case discussion. Dr. Arnab, I would like to ask you, would you like to go ahead with the discussion, or would you like to discuss the scenario that you sent? Or is it already covered, the questions that you have asked in the scenario? Then I can decide.
I think most of the questions have already been answered because my case also had some dilemmas between two or three principles. So I think
So
if
shall I?
time doesn't permit, we can go ahead with the discussion.
Yeah, thank you so much. Sanghamitra, there are a lot of questions in related to the, I think, towards the last few scenarios.
Yes.
So what if the family agree with, I mean, I think I'll start with Manjari's question. Just like doctors aiming to cure, even the patient and relatives most times don't know of anything, but try to do everything to treat and prolong life without realizing the patient is suffering more. So hence, family needs to understand, right? Yeah. I think that was the comment from Dr. Manjari. Can they take legal action against us? From Dr. Nari.
Can they take legal action? No, no. They. Why would they take legal action? See, why do doctors generally land up in litigation? The most important fact that I have found out, after doing palliative care classes, the trainings that we have had, we are not, honest with our patients or their caregivers. We have a problem of being judgmental. We also have a problem of using a lot of medical jargon. I think we will need to come to their place. Just it's similar to, how you teach a child, a small kid in the school. You have to be at the level of the child. So here you need to be at the level of the patients and the caregivers. Sit with them across the table. Give them the time that is important for you to give them, because this time is going to fetch the patient's belief and the trust on you. So once you build that up, I can say that nobody can actually take you to the court. Nobody. So they can never take any legal action. Also, please take care of your documentation. If you have a documentation is a huge chapter in palliative care. There are a huge lot of things that we document, right from day one to even the bereavement support. So please document everything. Documentation will be one thing that will always help you to look back at what you have told, what you have discussed, what you have jointly come. See, there are certain situations where the family is bound to actually go off track. Then we say, somebody from Dubai has come up very recently and starts kind of polluting the whole relationship between you and the patient, or you and the family. And that is where things might seem to slip out of hand. But having said this, again, it is always your prerogative to use your communication skills. I rely completely on my communication skills to get the benefit of doubt for myself from the patient and the family side. And there have been instances where I have taken care of very, very high profile patients of the society also, surrounded by, a lot of government officials related to the family and the patient. Sometimes, I remember I've taken care of, a 78-year-old lady suffering from pancreas with a lot of jaundice and abdominal metastasis. And she was one of the high-profile patients. She was the mother of an additional SP of one of the very dreaded districts of Assam. But I was successful in, bringing them to one plane as my own intention, because that was what was needed at that point of time. And they had actually, they were extremely happy about, how I had taken care of that patient, how I had stopped their mother from getting inside the ICU and, giving her a gift of death. So I think communication skills are one important thing that needs a lot of refreshment all the time, a lot of polishing all the time from your side, and you will need to depend a lot on your communication skills. And I will actually, always press upon the fact that you must always practice communication skills with everyone.
There are a few questions regarding the oxygen ICU shifting and things, but I assure you that will be covered in the end of life care session and the end, where I will have those conversations. We have an extensive session on that. Maybe one question that Dr. Yadav has asked: suppose that chemotherapy and surgery is going to prolong life for a few months, do we need to go ahead with? It's kind of asking about the balance between the quality of life and the survival in terms of months. How would you choose?
For a surgical condition, surgery and chemotherapy will add only a few months to the life. In that scenario, should we give palliative care and good quality of life instead of surgery plus chemo, which reduces the quality of life but increase the survival by a few months? This is the question, right, Sridevi? Yes. So, yes, Dr. Yadav, we will actually not go with the palliative, surgery or chemotherapy because of the fact that there is, documented evidence of chemotherapy and surgery reducing the quality of life and also decreasing the survival. And you will find a number of evidence in the literature which says that stopping chemotherapy and surgery would actually increase the survival along with a proper palliative care, which is intended to completely manage the symptoms and pain of that particular patient. We have actually seen that. You'll find a lot of papers in the literature. They are filled with excellent, lovely papers, lovely research work done outside India. There are a lot of research going on in this area in India itself. So I would actually suggest you to go through all the papers, because we are a scientific community. We do evidence-based medicine. So I request you to do the same with your patients also, and not just go by somebody saying it कि नहीं भाई chemotherapy दे दिया तो अच्छा हो जाएगा, ये हो गया तो surgery कर दिया तो अच्छा हो जाएगा. No, it's not like that. Please do not believe in my words also. You go and search in the internet. You will find hundreds and thousands of papers floating in there. They're free, and please go through them. Read and instead of searching in the Google, just read these papers, and they're going to give you a lot of knowledge about all these ethical dilemmas that you go through.
Thank you, Sanghamitra. I think Dr. Arnab's presentation was also very interesting. I'm so sorry so Dr. Arnab would like to discuss a few points from that, maybe the last. Dr. Arnab, you can just take us through the presentation, just to give an idea of what you are planning to tell. I think that should be fine.
Yeah, I'll just, we can actually go to the last slide. I'll just tell a gist of the patient whom I had. This is actually an 8 years girl who had a congenital obstructive hydrocephalus somewhere in the third ventricle, and doctors had actually not advised for a shunt surgery when she was young, and now she is bedbound, dependent, and she's actually at the care of the mother. She has contractures in her hands and legs, and she doesn't verbalize. She just coos and makes some sort of snorting noises whenever she is hungry or she is passing urine or she has passed stool. So she is completely dependent. So I just wanted to ask ma'am the last two questions, because the first part already ma'am has already covered in her wonderful presentation. So just the last two questions on how do we train ourselves to take these hard decisions. And as you also mentioned, ma'am, that if the patient takes a decision, then we have to kind of respect that decision. But sometimes it kinds of affects our peace. So how do we protect our peace against their autonomy when they don't know, but they still won't listen to our advice? So this 8 years girl actually came. So she's bedbound. She had hydrocephalus. She had contractures. Her development milestones were somewhere around 1.5 years of age. She came with a fever for 2 days, and the fever was as high as 106 and 108, and higher that our thermometer could not read the fever. We kind of decided not to do a lumbar puncture because she had papilledema, and the nearest CT scan center is kind of 2 hours away, and there was no way to ensure whether she had a raised ICT and a danger of coning. So we actually gave her symptomatic treatment, gave her broad spectrum antibiotics for 5 weeks, and the fever settled, and we actually sent her home on a OG tube. And this happened a month back, so she still survives to this day, and the family is giving NG feeding and all the drugs through the OG tube, and the basic care as they were giving. The mother is actually currently 32 weeks pregnant, so they couldn't afford to take her to a higher center. And my dilemma was whether to do a lumbar puncture with the knowing the risk of having coning and then ICU admission, intubation, versus broad spectrum treatment, and just giving palliative kind of treatment to them. So something which is affordable and something that can be continued at home. So that was my case. Uh, so, ma'am, I want to ask that last two questions to you. Thank you.
Okay. Dr. Arnab, you're going through a hard time, I'm sure.
Yeah, this was a difficult decision for me to take, and our team to take, actually, not to kind of get a definitive diagnosis and kind of work with the unknown. But somehow the patient survived and the fever improved, and they have not spent much resources, and they still come back, and we clean the OG tube and teach them a little bit of self-care, and they continue to take care at home.
So where do you think you are going wrong here?
So my dilemma was, if can we just go back to the psychological aspect, the slide, please.
Which slide you would like to?
The ninth slide, the ninth number, psychological aspect. Psychosocial aspect, yeah, the previous one, yeah. So my dilemma was here, that whether I was under treating a girl who was known hydrocephalus, risk of meningitis, came with a high fever, deterioration of consciousness and her basal level of functioning, and not doing an LP and just giving broad spectrum treatment with the fear that she could cone and actually have a poor prognosis because of the intervention. So that was my dilemma, ma'am.
So do you think that you've undertreated the girl?
Uh, I don't think, but one of my colleagues thinks that I have undertreated that girl.
So have you actually, talked it out with your colleagues? Because I understand by the things that you've shared with us today, you are still in a kind of a guilt feeling that I have undertreated.
Yeah, sometimes I still think that whether we could have actually done an LP, got a diagnosis, and maybe it would have shortened their IP stay. Yeah, so yeah, I do
Dr.
have that.
Arnab,
Yes.
yes. So Dr. Arnab, we need to understand one thing in life. There is always a scope of improvement, right?
Yes.
We are not perfect people, number one. Number two, we are human beings and we are, challenged by daily errors that we do, and we need to accept that particular fact. Now, for the question of undertreatment, you have actually listed out a lot of points here. You don't have a CT scan nearby. You don't want to intubate. You don't want her to cone and die. So there is the question of undertreating here. I think you have perfectly done the right kind of a thing by doing what you have had already done for this patient. And the point that this patient is still surviving is itself a testimony that you have actually done the best. So I sincerely don't think that you have undertreated, and you have perhaps taken the right decision for not doing anything at one point of time. कितना आप एक organ को काट के छोटा करोगे? That is the question. So I sincerely don't think that you've undertreated. Right now, all you need is self-care. So self-care for people like us, those who are, intensely involved with the person. We generally personalize everything when we are with a patient, So you need a lot of self-care. Self-care is an important part of palliative care. Please go through self-care measures. There is, I think, Pallium India support doctors for self-care also. If I'm not wrong, they have a helpline. I think you should talk it out the way you have actually talked it out today with us. I sincerely don't think you have undertreated. There is no ethical dilemma out here. It is a kind of guilt that you have in your mind that why am I not able to, do a CT scan for this patient? काश ये CT scan इस बच्चे के घर के पास होता, right? हाँ?
Yes.
काश ये बच्चा उसको वो सब कुछ मिलता जो एक छोटे बच्चे को मिलना चाहिए, with all the kind of facilities that a small kid. It's impossible to see a kid dying like this. It is not possible at all. So I think right now, with the available resources, whatever you have done your best. I don't really blame anyone or not even the situation for what it is like today. But I think you've done a great job by, simply taking care of this child and, being so sensitive about the whole issue. That is it.
Thank you. Thank you. Yeah, that's what I wanted to discuss here. Thank you.
Thank you so much, Sanghamitra, and thank you so much, Arnab, for that question, so that we got some wonderful insights from Sanghamitra. Yeah, thank you so much, everyone. Yes, there were a lot of questions on end-of-life care and ICU and oxygen and medications. I assure you that we will definitely cover those topics in end-of-life care session by one eminent faculty. So yeah, I think. Yes, Dr. Pinky, you wanted to tell something?
No, thank you.
Thank you so much, everyone. Thank you so much. I can see one more hand. Sorry, I'll take that last question. Dr. Rajni, yes. Dr. Rajni, would you want to ask a question? Maybe I missed it. I don't know. Yeah, so thank you so much, Sanghamitra, for the wonderful session as usual. We had a lot of comments and interactions in the chat. Thank you so much.
I really enjoyed it.
Yes, yes.
It was lovely. I mean, I also learned a lot by discussing everything with you, and it was really wonderful. Thank you so much. Thanks a lot.
Thank you, sir.
Thank you, Dr. Sanghamitra, for joining us. We already know your busy schedule, and personally, I would request you to take good care of your health and do come back more healthier in the coming sessions. So, thank you for your time. Thank you for that, and thank you every participant for your active interaction, because this is what makes our learnings so fruitful and so successful. Please continue this till the end of the session, and please do carry the baton of palliative care across India, wherever you are in the world. So with that positive note, this is Sri Priya along with Dr. Sanghamitra Bora and Dr. Sridevi Warrior signing off from the TIPS Eco Hub. See you in the next session with another interesting topic and another eminent faculty. Till then, everyone, stay safe, be happy. Bye-bye.
Bye. Bye.